Thank you, Professor Kamlesh, for your very informative talk. And now let me present some of the case scenarios with you. Dear colleagues, we started using Rybelsus before the launch, and the first time it was available with NMC in August 2021, and from the day one I have been using this agent in my clinical practice. And let me share 3 of the cases, and these cases I have seen them under my follow-up very recently. First case is 41 years man. His first visit was on 18th November 2021, and with history of type 2 diabetes mellitus, diagnosed 1.5 years ago. He has uncontrolled diabetes with HbA1c was 9.9%. He was having mild osmotic symptoms at that time. He also had recent weight gain, although when patients have osmotic symptoms, we expect patients to lose weight, but sometimes patients overcompensate by overeating. So he gained some weight. He also complains of myalgia and fatigue, but he did not have any numbness of feet or burning sensation, any visual disturbance or swelling feet, or any evidence of macrovascular complications. At that time, patient was, when he came to me in November, he was already on metformin, sulfonylureas and DP4 inhibitors, and which is the majority of the patients we find the standard treatment, and this has been going on for the last decade or so. So with this background, we have to decide what are our targets for this patient. But let me also explain to you what was his clinical examination. Clinically, he was obese. He is a BMI of 30.52, weight was 88 kilograms. He had elevated blood pressure, but that was maybe during the hospital stay, but generally his pressure has been normal. He had normal kidney function test. His LDL 2.59, which I will say okay, but better to have LDL level of less than 1.8. HDL was on the lower end and triglyceride was normal, and this is typically what we see in South Asian patients. So his comorbidity was elevated pressure. Now if you look at this patient, what should we focus on? So if we first thing is that he has elevated blood glucose levels, elevated HbA1c. So our first goal in this patient should be bring down his HbA1c and glucose control. Second is he is obese, so we have to reduce his weight. And thirdly, he is overweight, he got elevated pressure, he got diabetes, and this is a milieu for the cardiometabolic diseases. So he is at a risk for the cardiovascular disease. So this also we have to tackle. So during this was our discussion. Patient was, I assessed him clinically and biochemically, and we discussed treatment plan. Now this patient already on metformin, DP4 inhibitors, and also on sulfonylureas and uncontrolled diabetes. So we need to give something to him so that we can reduce his weight, we can control his diabetes. So I discussed with him the option of oral agents which are still available with us, like SGLT2 inhibitors, pioglitazone, then weekly injectable, and of course weight reduction with lifestyle modifications. So this is what I planned for him after discussion, that we will focus majorly on medical nutrition therapy. Let me tell you, 80% of patients of type 2 diabetes is happening because of lifestyles. The first and foremost treatment is change in lifestyle. Although a patient was doing some lifestyle modification, but that was not enough. So I spent myself 15-20 minutes with him to explain about his diet and exercise plan, and I also asked him to meet our dietitian. Then this was my treatment plan. I started patient on metformin 850 milligrams twice daily, pioglitazone 15 milligrams, and Rybelsus or oral semaglutide 3 milligrams during first month. That was followed by 7 milligrams every day. Now, you will be surprised why pioglitazone. So, I just want to tell you that is from South Asia. South Asian patients have a very significant contribution of insulin resistance, and they really respond very well to small doses of pioglitazone. So I use pioglitazone in my clinical practice, but in a smaller doses only. So, this was the treatment plan for him, and now pioglitazone and metformin also available as a combination. So, we can give him less number of pills to improve his adherence. So, this was the most recent visit with me. He came to me on 31st of March 2021, and he has lost 3 kilograms of weight, and his A1C has reduced from 9.9 to 6%, which is remarkable. Nobody will believe that A1C can come down within a span of 6 months time from 9.9 to 6%. With the change in medications alone, but let me tell you, this patient doing very good diet and exercise plan, and Rybelsus has really helped him. How did it help Rybelsus? With this, one more important aspect of type 2 diabetes mellitus patient is that they feel more hungry. They eat more carbohydrate, they feel hungry. So, when we give them GLP-1, GLP-1 reduces their appetite, and this has a major role to play. Although if you look at the international studies and European and US data, they usually say that diet alone may not be the major factor for reducing HbA1c, but what I have seen in my observation that South Asian patients and overall in MENA region and Asian patients, they eat more carbohydrates. So, when we give them GLP-1, like Rybelsus, their appetite comes down, they reduce weight, and that there is significant, very quick response to their hyperglycemia, and that is what has happened to this patient. Within a span of 6 months time, his HbA1c from 9.9 has come down to 6%, which is in pre-diabetes range, and he is on 3 tablets only. A combination of metformin, pioglitazone after breakfast, metformin alone after dinner, and very early morning before he takes anything. As soon as he gets up, he takes Rybelsus 7 milligrams. Now, after 1 month, I increase his dose to 7 milligrams, and he takes as soon as he gets up with half cup of water, and then for half an hour he does not eat or drink anything, and this he has been doing very religiously. So, and that has really helped this patient. So, I think hats off to this patient for following diet, exercise and our medical treatment. And if you look at the number of medications, only 3 tablets. So, his adherence is very good, he is highly motivated, and the results are in front of us. Patient 2, a different problem. He is 36, quite young man, again from India. His HbA1c is 7.1. He first visited on almost same day, 24th of November, and he is a known case of type 2 diabetes mellitus since August 2018. And when he came to us, he was complaining of mild giddiness and chest discomfort. So, I evaluated it from cardiac point of view. His ECG was normal. He was also seen by our cardiologist, and his cardiac status was normal. There is history of weight gain, but he again, like last patient, does not have an history of micro or macrovascular complications. But most important aspect or problem in this patient is that he is intolerant to metformin. He is not able to even tolerate 500 milligrams of metformin. So, in our clinical practice, around 5% patients, they do not tolerate metformin at all in smallest doses. So, we have to use other options of these patients. So, his clinical examination is BMI 27.92, which is overweight from international criteria, but from Indian criteria, he is obese, his weight 76 kilograms, his blood pressure is normal range, kidney functions are normal. He got a triglyceride which is on the higher side, 2.4 millimoles, not milligrams. He got LDL of 2.04, which is fine for his age, and his HDL on the lower end. This, as I told you earlier, this is what we get in most of the South Asian patients. They have high triglyceride, low HDL, and their LDL level is not very high, but this is a important risk factor for these patients for cardiovascular disease. He, in addition to type 2 diabetes, he also has hypothyroidism, and he is on small doses of thyroxine, that is 50 milligrams. And I'll tell you how we face this challenge of using thyroxine and oral semaglutide in my treatment plan. So, in this patient, what we are looking for? We are looking for a better glycemic control. He is 36 years old only. So, I will put his A1C goal at less than 6.5, not 7. We want his weight to come down further. We want to reduce his cardiometabolic risk factor. But most important point from my point of view in this patient is, because he is intolerant to metformin, we have to give him something to control his hyperglycemia and also make him comfortable. So, I assessed him clinically and biochemically. Biochemically, as I already told you, his HbA1c 7.1, LDL normal, triglycerides slightly high, and then I discussed treatment plan. With each and every patient, when they are coming to me first time, I spend a lot of time. So, my appointment time may be 15 or 20 minutes only, but for first time patient they come to me, I spend 30-40 minutes with them, and I myself explain diet and exercise, and then if they wish they can meet dietitian. So, the treatment plan was, I discussed with him the option of other oral agents including sulfonylurea. Let me tell you, he is on pioglitazone, metformin intolerant. So, we have all options available. We can give him sulfonylureas. Sulfonylurea is good, but his overweight may not be a great idea to use this. SGLT2 inhibitors again good for him. He is slightly overweight. We can use that also. But we want to reduce his, we have to reduce his weight by lifestyle modifications, and some medications will reduce weight and keeping in mind intolerance to metformin. So, this is what I planned for. I continued pioglitazone 50 milligrams and I explained, and then he agreed to take oral semaglutide 3 milligrams during first month, which was followed by 7 milligrams from second month onwards. Most of my patients as of now around 7 milligrams, very few of them are 14 milligrams, but because when I am increasing dose from 7 to 14, I always ask them, are they comfortable? If their HbA1c in target range, if they are comfortable with 7 milligrams, they have reduced desirable weight, I usually do not increase. But of course, some patients where we are not able to achieve A1C level in target range, or weight is not reduced to our target level, we can go from 7 to 14, and which is quite fine. And as I told you, some of my patients are already on 14 milligrams of Rybelsus. So, this is what I planned for him, and these are the results. He has met me last week on the 13th of May. His HbA1c is reduced from 7.1 to 6.4, which is the target range. I told you, for me, his goal of HbA1c is less than 6.5. So, we have achieved HbA1c of less than 6.5. His weight has reduced from 76 to 69. So, I think quite good. Almost he has lost 6.3 kilograms, which is quite remarkable. And he has tolerated oral semaglutide very well. His appetite has come down, he feels light, he feels comfortable, and no more GI side effects. In the beginning, he had very mild upper GI side effects like nausea, vomiting, but within 1 week time, he tolerated semaglutide very well, and he is right now on 7 milligrams of semaglutide and pioglitazone 15 along with the thyroxine, and he has done very well. And again, this particular patient, within a span of 6 months, he has achieved all his goals and is motivated to continue and maintain this. And if he continues to do so, he can live normal and long life. Now, let us go to the third patient. She is 50 years, woman. Now, she has a slightly longer duration of diabetes. She has diabetes since 2015, so around 7 years of diabetes, and she has been taking sitagliptin metformin combination almost from the beginning, and she has good control of diabetes. Look at it, HbA1c is quite fine, 6.1 will be fine, and I think most of the patients will say there is no need to make any change, and this is what we have been doing so far. But when I asked her in detail, she comes out with the one point and one complaint that, doctor, I had to struggle very hard to maintain my weight, and really she has to eat very less, and she feels increased appetite in between, and she has to really struggle to control her appetite. So this is troubling her. And till recently we did not have, and she was not willing for injectables. So she has been under my follow for a long time. So when Ribelsis was introduced to her, I talked to her that we have one option now which will take care of your weight and your appetite, which is your major problem. This new molecule can help you. So patient agreed to that, and I'll tell you what we planned. And fortunately this patient also has done quite well. You can her A1C has been in good range for a long time, so she does not have any evidence of micro or macrovascular complications. If you look at her clinical parameters, her weight 69.5, BMI 28, so she is overweight or obese as per as Indian criteria is concerned. She has high normal blood pressure. But what I noted, most of the patients, when they are coming to the hospital, their BP is few notches higher than normally what they get at the home monitoring. So normal kidney function test, her LDL level is 2.79, which is out of range for her definitely. For the 50 years lady, we want her LDL at least less than 100 milligrams per deciliter, or better to have less than 1.8 millimole, so less than 70. She is a good HDL, her triglyceride is low, normal, she does not have any comorbid conditions. So treatment targets for her: one, better glycemic control. I think her glycemic control is quite good. So even if she maintains 6.1, I'm very happy, because this is already in pre-diabetes range. Weight reduction, yes, I will be happy if she reduces her weight further and can bring down her BMI less than 25. And cardiometabolic risk, she does not have many of the cardiometabolic risks, except that she is diabetic and she has high LD levels, no hypertension, but she is very close to menopause. And let me tell you, after menopause, the risk of cardiac disease in women is as high as men. So she is in that range of cardiovascular risk. So we must address her cardiovascular, cardiometabolic risk also. So this is what did again during her consultation. This is what we discussed. As I told you earlier, her major problem is maintaining weight and food control due to cravings and increased appetite. Now generally GP4 inhibitors do not cause hypoglycemia, and they are weight neutral. These do not cause hypoglycemia and increase appetite, but some patients I have noted with that DP4 inhibitors also increase appetite, which is a subtle symptom of mild hypoglycemia. So that is possible, that is what she is having. So I discussed with her option of using GLP-1, and like most of Asian patients, she was not willing for injectable. I'll give her both options, that we have option of giving you weekly injectable GLP-1 or oral GLP-1, and she said, doctor, no, I'll be happy to take oral agent. So this is what we did for her. Medical nutrition therapy, again she has been under my follow-up, so she is doing quite fine, but again I re-emphasize on medical nutrition therapy. Metformin, we continued. Sitagliptin, whenever I am using GLP-1, I always remove from the very beginning. There is no point in giving combination of DP4 inhibitors and GLP-1, because GLP-1 are super, they are much higher value than DP4 inhibitors. So I started her on oral semaglutide 3 milligrams for the first month, and followed by 7 milligrams to be continued, and she has again tolerated it quite well. Now her last visit was recently, and her HbA1c has come down to 5.7 with this, which is in normal range. So from pre-diabetes range with the oral medications, we have been able to bring her HbA1c down to normal range, which is excellent, and her goal of reduced appetite and weight control has been achieved. because now she feels light, she does not have craving for food, and when she starts eating food, after eating small quantity of meal, she feels full, and she is quite happy with this. And let me tell you what is the importance of glycemic control and treating diabetes patients well. Not recently, there is one very good study which has shown that the type 2 diabetes patients, if they have uncontrolled diabetes, their lifespan is reduced by 6 years, and if they have some comorbid conditions like hypertension or cardiovascular disease, then their lifespan is reduced by 12 years. So when patients are coming to me, my goal is to give them long and healthy life without hypoglycemia, without weight gain, and when I do that, I feel very happy. And similarly, for this patient, you can see she is 50 years, the lady, HbA1c 5.6, she is just 2 medications. Only thing I can do now, what I have done this visit, that she was earlier taking metformin twice daily, I have reduced metformin one time at night, and early morning she takes Ribelces, and she is very happy, and so I am. Now finally, this is what I presented. I presented the first case where this young man had type 2 diabetes mellitus, which is uncontrolled with HbA1c is 9.9, and he was overweight. So our goal in this patient was to reduce his weight and to get a good glycemic control. So he reduced weight, and his HbA1c came down from 9.9 to 6.0 within a span of 6 months, and excellent. So goal achieved. Second patient, he had HbA1c 7.1, but his problem was he was intolerant to metformin. So this patient, again I used pioglitazone along with the oral semaglutide, and he was very tolerant. His HbA1c from 7.1 came down to 6.4, again goal achieved. And third patient, which I have just discussed, she was struggling to maintain weight and had craving of food with metformin and DP4 inhibitors, and when I changed this patient from DP4 inhibitor to GLP-1 oral, she reduced weight, her appetite has become normal, and she does not have much craving for food, and her HbA1c has come in normal range now. So for this patient also goal is achieved. So for all these 3 patients, by using oral semaglutide within a span of 6 months time, I have been able to achieve their treatment goals. Thank you so much.